So, sorry. I think now it's all right. Sorry, once more. Professor Kim, please tell us, how can we differentiate central positional nystagmus from peripheral one?
So sometimes, it is not easy to differentiate central from peripheral, positional and nystagmus. But if you take the histories about the symptoms, the patient with central positional nystagmus mostly report vague dizziness and imbalance rather than the positional vertigo. And the characteristics of nystagmus is a little different from the peripheral one. So in case of paroxysmal central positional nystagmus, the nystagmus is maximum at onset and then decrease. But as you know, in peripheral cases, there's a gradual build-up the nystagmus over 10 to 20 seconds, and then there's a gradual decrease. So that's one thing. When I see the patients, I focused on the history of the presenting symptoms and the characteristics of nystagmus and other findings of the oculomotor, findings suggesting the central lesions or other, neurological findings suggestive of central lesion. And finally, you confirm the diagnosis by, disclosing the lesion responsible for the central positional nystagmus on neuroimaging.
Thank you. A positive head impulse test we usually consider as a sign of a peripheral failure, but do you see it in some central vestibular disorders, and how does it look like?
In central lesions, even though the head impulse test is positive, it is very subtle, less obvious than that observed in the peripheral vascular lesion. So even in case that lesions involving the cerebral flocculus or the brainstem, the head impulse test may be positive. But if you are very familiar with the patterns of the corrective saccade, then you can see the corrective saccade is not as obvious as observed in peripheral lesions. So, and the head impulse test may be observed in both directions, even in unilateral lesions. So those are the features that can tell central from peripheral, the positive head impulse test.